Hello and welcome to Cleveland Clinic Ultrasound course. My name is Dugar. I am the Director of Point of Care Ultrasound for IHI Cleveland Clinic, and we are going to talk about advanced cardiac ultrasound. You might have gone through the video on basic cardiac, and the difference between basic and advanced cardiac is specification. So if you look at this weight, if you say it's very heavy, that is qualitative assessment, and that's basic cardiac. But if you say it's 35 pounds, that's advanced because now you're getting quantification added to it. Here we'll talk about various measurements that can be performed very easily at bedside, assessing the most important ventricles and the valves. So the first one that we are always worried about when our patient has shock or respiratory failure is LV systolic function. There is something called EPSS, which is E-point septal separation. And what we are trying to do is measure the distance between the mitral leaflet tip from the septum during early diastole. Here we have a good example of a video showing how to measure EPSS. We have a nice parasternal long axis view with an M mode that is passing through the mitral leaflet tip. You can see how the septum is parallel to the surface of the screen, and we are getting early and late diastolic filling measurements. It is very important when we are measuring the EPSS that we know that what is the long axis, which is basically an axis that is passing through the apex of the LV right through the mitral valve. And then we try to get your M mode exactly perpendicular to it. Once we get the M mode measurements, what we do is measure the distance between the septum, as you can see in this image, from the early. It's very important to know it's early diastolic filling. And the measurements that we see usually are more than 7 mm. If the distance between the septum and the leaflet tip in early diastole is more than 7 mm, there is a high possibility the patient has impaired LV systolic function. If it is less than 5 mm, it's very normal. So these are the two cases you can see. In one case, basically there is no space left on the top image between the septum and the early diastolic filling. While the image below, you can see a pretty decent separation between them, suggesting a normal cardiac function from an impaired cardiac function. This is another measurement that we often do to assess the LV systolic function called MAPSE, or mitral annular plane systolic excursion. You get a nice apical 4-chamber view, and then you pass an M mode that crosses the LV apex and the lateral annulus of the mitral valve. You get an M mode like that, which is very similar to TAPSE, and you measure the peak distance traveled by the lateral mitral annulus. The values that can assess what the LV systolic function is doing is more than or equal to 11. You have a very high probability that the LV systolic function is normal. When it is less than 8 mm, you are having a case of impaired LV systolic function. Some cases have suggested that you should be averaging the measurement from the medial and lateral mitral annulus. I try to do both just to get an average and a better assessment of LV systolic function. This is a study that was published that looked at MAPSE in a case that we are more interested in, which is LVEF in mechanically ventilated obese patients. These are the patients that you have a lot of challenges when you are trying to do EF assessment, given that the image quality may not be appropriate. And what they found was MAPSE compared to ejection fraction using eyeball technique and Simpson technique, it was pretty well correlated, where the R value of R of 0.85 and 0.89, suggesting that in cases where it is challenging to get EF using eyeball or Simpson, MAPSE can be used as a surrogate to assess LV systolic function. The next method that we all know about is the Simpson method of assessing LVEF, and all you are trying to do is get a very good image of the LV in apical 4-chamber view and try to measure the volume of blood inside the LV cavity during systole and diastole. And all you do is minus the volume that is assessed during end systole from end diastolic, giving you stroke volume. LVEF, or left ventricular ejection fraction, is basically a stroke volume that is indexed to the end diastolic volume, giving you the LVEF. Now this is one measurement that we do often in our ICU when we are doing advanced echo, that is Doppler derived cardiac output. What we are trying to do is measure the volume of blood passing through a certain area in the LVOT. And if you know the amount of blood leaving that area, you can assess the stroke volume. The two views that we obtain is parasternal long axis and apical 5-chamber view. Apical 5-chamber view is obtained after obtaining apical 4-chamber view by tilting the probe downwards, where LVOT and the aorta comes into the picture. We try to measure the cross-sectional area of the LVOT, and that is using the formula pi r square, since the radius is obtained by measuring the distance between the aortic valve leaflet in the parasternal long axis. Once we have the LVOT trace or area under the curve, which we call velocity time integral, you multiply both of them, the LVOT cross-sectional area and the velocity time integral, giving you stroke volume. And if you multiply your stroke volume with your heart rate, you get cardiac output. Here is a real-life example of how we do it. We get a good parasternal long axis view. I always try to zoom in so I can get a very good assessment of the LVOT radius. Here you can see that we are measuring the LVOT radius at the sites where the aortic valve leaflet touches the septum and the mitral annulus. And then you get the radius and you try to basically do the pi r square formula here. The apical 5-chamber view, we use pulse wave Doppler right at the same point that we have gotten the LVOT cross-sectional area. How do I know I got a good trace? Is that the trace will be empty inside and has a white lining at the outside, suggesting that we got a good envelope of the LVOT trace, and we measure the area under the curve, giving us the LVOT velocity time integral. Advanced echo not only gives you cardiac assessment or cardiac output measurements, it also tells you what are the filling pressure. That is one of the advantages of using advanced. So here is a good case of trying to measure left-sided filling pressure. The way we do it is using, again, tissue Doppler, which instead of measuring the velocity of the blood, measures the velocity of the myocardium. We get again an apical 4-chamber view, and we use tissue Doppler with the pulse wave right at the medial mitral annulus and lateral mitral annulus, and we try to measure the early diastolic relaxation. We average it out, and the other measurement we try to get is again diastolic filling of the left ventricle by putting a pulse wave right at the mitral leaflet tip during diastole. Here you can see a very good example of getting early and late diastolic filling of the left ventricle. We measure the peak velocities, giving us a E velocity and an A velocity. Now the Doppler parameter that we use to suggest what is the filling pressure or pulmonary artery occlusion pressure, again, it's just an estimate, but a good formula that has been validated is using E over E prime and adding 4 to it. That gives you a left atrial pressure or the left-sided filling pressure. When the most important question in our ICU is the left-sided filling pressure elevated, or is the respiratory failure because of pulmonary edema? Few of the parameters that has been validated with decent sensitivity and specificity is EA more than or equal to 2, your E over E prime more than 10, and your EA more than 1.4. All these parameters have shown that they can predict with good sensitivity and specificity the associated occlusion pressure in the pulmonary artery. RV, we do see a lot of patients with RV dysfunction in our ICU, especially with respiratory failure. One of the parameters that you can use is comparing the size of the RV to the LV. It's a surrogate for RV strain. Again, you want to use multiple measurements and multiple views to confirm this finding. But if you have an RV-LV ratio that is altered, which is basically more than 1, where your RV end diastolic area as measured here is more than your LV end diastolic area, you have a pretty severe RV dysfunction. And if you add it with a paradoxical septal motion, that tells you that RV is severely impaired. Other measurement that we often do in our ICU is TAPSE, which is tricuspid annular plane systolic excursion. And the way we do it is get a nice apical 4-chamber view or an RV focused view and have an M mode that passes through the LV-RV apex and the lateral tricuspid annulus, similar to how we did MAPSE. and we try to measure the displacement of the lateral tricuspid annulus during systole. A normal value is more than 1.7 centimeter. If it is less than 1.7 centimeter, that is an impaired RV, and the lower it is, the worse the RV is impaired. Similar to how we do TAPSE, we have another measurement, but instead of using displacement, we measure myocardial velocity. And the way we do it is by using tissue Doppler. Here you can see an example of an apical 4-chamber view or RV focused view, where we are putting the tissue Doppler right at the lateral tricuspid annulus. We look at the motion of the lateral tricuspid annulus during systole, and we measure the peak systolic velocity. A normal value is 14 centimeter per second, so it's a velocity. Impaired is when it's less than 9.5 centimeter per second. Similar to how we get the left-sided filling pressure, we can also get the right-sided filling pressure. The way we do it with using echo is by measuring the tricuspid regurgitant velocity. We can get it in multiple views: parasternal short axis at tricuspid level or apical 4-chamber view, as in this case. Once we get the TR jet or tricuspid regurgitation jet, we put a continuous wave through that and measure the peak velocity that is obtained. That is converted into pressure using the formula 4V square, as in this case. And then once we add the right atrial pressure, which we will talk about in the next slide how to obtain, we get our RVSP. Another method to assess RVSP or your pulmonary pressures is using pulmonary artery acceleration time. This is usually done in parasternal short axis view at the pulmonic valve level. And we put a pulse wave right at the pulmonic valve, and we get a jet similar to our LVOT trace through the RVOT. We measure the time it takes to reach peak velocity from the initiation of systolic velocity, and a value less than 105 millisecond suggests that there may be normal pressure in the pulmonary vessels. The right-sided filling pressures are obtained by assessing the IVC and its changes with respiration. Again, this method is not validated in patients on mechanical ventilation or positive pressure. But in a spontaneously breathing patient, we can ask the patient to sniff, and the measurement that is obtained at end expiration and the collapse with sniff can tell you what the right atrial pressure are, and this has been validated and routinely used in our echo labs. As like this is the two cases you can see that were obtained in our ICU patient. One is a very small IVC with complete collapse, suggesting that the RA pressure is close to zero and may need resuscitation, while the other case is an IVC that is dilated with minimal to no respiratory variation. So again, closing comments: confirm finding in multiple views. I always try to corroborate my measurements in multiple views just to be sure that the view is not altering the measurement. A good measurement needs a good image. Always try to take an average of 3 to 5 reading. The qualitative assessment and the quantitative assessment are complementary. If you have a qualitative assessment that is saying something and the quantitative assessment saying something other, try to see why is there that discrepancy and have fun with your new skills. Thank you and have a great day.